You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for November 5th, 2021. This week, first a correction. FFR-guided PCI fails. The ischemia trial challenged. Perhaps QFR is the better way to assess coronary disease. And one of the most important studies of 2021. First, no COVID this week. We are moving on. I'll start with a correction on last week's podcast. Last week, I mentioned a research letter that was published in the Journal of the American Heart Association that reported on an increasing incidence of Takotsubo cardiomyopathy. But an academic cardiologist who is more familiar with the data source used in that study, this was the National Inpatient Sample Database, he let me know that I may have missed the boat. I was struck by the increased incidence of Takotsubo cardiomyopathy, but my colleague pointed out that there were many reasons that the National Inpatient Sample could show an increase in incidence. For instance, he wrote, it could all be due to coding practice. Now, with the introduction of EMRs, especially Epic, it has become much easier for people to select a very specific billing code for Takotsubo cardiomyopathy than it was previously. In addition, he suspected that a lot of the increase is just greater recognition of a condition that has been with us since the dawn of time. My colleague said that tracking procedures in the NIS or related databases is reliable, but tracking pure diagnoses is dubious. I still think, though, we're seeing more of this condition, but the bias of mine might have gotten away of proper critical appraisal of the study. By the way, I really appreciate this sort of feedback. Please keep it coming. This note came through DM on Twitter, but you can also reach me via comments on the heart.org Medscape Cardiology webpage where the podcast is posted. You can just email me on plain old Gmail. Next topic is FFR-guided PCI. The New England Journal of Medicine published yesterday the results of the FAME-3 RCT of FFR-guided PCI versus coronary bypass surgery, CABG, in patients who have multi-vessel coronary artery disease. FFR, or fractional flow reserve, is a surrogate marker of a stenosis. It's a physiologic measure. Basically, a catheter measures the pressure right before the blockage and right after. If there is no blockage, the FFR would be 1. If it was totally occluded, it would be nearly 0. And if the FFR is less than 0.8, it is felt to be significantly flow limiting. The therapeutic fashion is that physiologic measurements provided by FFR help guide the doctor in telling which blockages should be stented and which should be left alone. Visual inspection of a blockage on an angiogram with contrast isn't accurate enough, goes the thinking. Now, it's an enticing concept because it makes sense. My friends, that phrase, makes sense, should always raise your suspicions. Now to the trial. First, the background. Background is that we have 3 trials, Syntax, Freedom, and BEST, that all 3 reveal that coronary bypass surgery is better than PCI in patients with multivessel disease. But of course, medicine changes. These were old trials which used older stents, and many were done without the benefit of FFR. So a better brand of PCI might be as good as CABG in these patients. Thus, the FAME-3 trial tested whether FFR-guided PCI with the current generation stents and FFR was as good as coronary bypass surgery. The jargon that we would use for this sort of comparison is, was FFR-guided PCI non-inferior to CABG? And before I tell you the results, I want to say that this is actually a great use of non-inferiority testing, and that's because PCI clearly has a shorter and easier recovery than CABG. And if it was as good as surgery, most patients would choose the less invasive, easier procedure. Now, FAME-3 used an efficacy endpoint of MACE, major adverse cardiac events. Death, MI, stroke, or repeat revascularization was the composite. The non-inferiority margin was set at 1.65, meaning PCI could be 64% worse and still deemed non-inferior. That's a pretty wide margin. 1,500 patients were randomized at 48 centers in the FAME-3 trial. On average, patients in the stent arm got about 3.7 stents, and those in the CABG arm got about 3.4 bypasses. At 1 year, here are the results. 10.6% in the FFR-guided PCI arm had a MACE event versus 6.9% in the CABG arm. 10.6 versus 6.9, the absolute increase of 3.7% in the PCI arm translated to a hazard ratio of 1.5 or 50% worse. Now you might say, that's non-inferior because 1.5 is less than 1.65. But no, you can't use the point estimate of the hazard ratio in non-inferiority trials. You have to consider the upper bound of the 95% confidence interval of the hazard ratio. And here, the hazard ratio of 1.5 had a confidence interval that went from 1.1, 10% worse, to 2.2, more than twofold worse. And since the worst case scenario, the upper bound, was greater than the non-inferiority margin of 1.65, we say the FFR-guided PCI was not found to be non-inferior to CABG. When the trialists reported harder endpoints of death, MI, and stroke, the rates were 7.3% versus 5.2%, still a 40% increase in events in the FFR-guided PCI arm. As expected, the rates of major bleeding, arrhythmia, and acute kidney injury were higher in the CABG arm, and CABG will always have more immediate post-op risk. When you look at the components of the endpoint, there were no outliers. Pretty much each of them were higher in the PCI arm. And now recall also, friends, that these were only 1-year results. That PCI could not match CABG at 1 year is quite remarkable. Recall that the benefits of CABG accrue over time, so these curves are going to get even wider, I suspect. The hope was that FFR would lead to more judicious stenting, which would be enough to equal CABG. This was clearly not borne out from the evidence, though. Well, interventional cardiologist Ajay Kurtain tweeted that his take-home was that for 3-vessel disease, you got to take patients off the table, which we have been doing, and he says the differences will be even greater with longer follow-up. Kurtain added that the physiology is just one part of optimized PCI, physiology being the FFR measurement. He wrote, 12% imaging in the study aiming to match CABG doesn't cut it. His point was that imaging was used in only 12% of the PCI patients. In other words, use of imaging would improve stenting results, and imaging may allow for better stent placement, and that may lead to less need for repeat procedures. Maybe. Image-guided stenting as a way to get it to measure up to CABG is indeed a reasonable hypothesis, and it surely could be tested in the same way as FFR was just tested. I would offer 2 take-homes of this trial, one similar to Dr. Kurtain and one slightly different. First, a similar one. FAME-3 had a very lax non-inferiority margin. It used a fair definition of MI, and it clearly showed CABG was the better strategy. And if CABG is better at 1 year, it will surely be better at 3 and 5 years. So yes, patients with multivessel disease should come off the table and CABG should be recommended. Now, my second take-home pertains to the lessons learned from the failure of FFR. I see FAME-3 as totally predictable because a neutral Martian view of FFR would be, how in the world did this procedure get accepted as standard operating procedure? I will link to a 2019 editorial from David Brown and Andrea Soares in the International Journal of Cardiology, and they wrote about the 4 fallacies of FFR. The first fallacy is that a focal obstruction is on a direct path to death and MI. I mean, we learned very early in our training that in general, high-grade stenoses are less likely to rupture and cause MI and death than mildly obstructive younger lesions. The second FFR fallacy is that microvascular disease is not relevant to patients with angina. Of course it is, and FFR measures only the epicardial stenosis. The third fallacy of FFR is that it improves outcomes through targeted lesion selection. Now, one interpretation of the original FAME trial was that PCI reduced death and MI because fewer stents were placed in the FFR arm. And the fourth fallacy of FFR is that it improves outcomes relative to medical therapy. But recall that in the FAME-2 trial, FFR beat medical therapy, but the entire reason was higher rates of urgent revascularization. Well, FAME-2 was unblinded. Patients in the non-stent arm, the medical arm, knew they were untreated with stents. And Christopher Rajkumar and colleagues call this subtraction anxiety. So what do you think happens when a patient with a blockage left untreated with a stent has 10 seconds of pain in his left pinky finger? Yes, they go for repeat revascularizations. So in sum, FFR as a standard practice is a classic example of therapeutic fashion established on dubious grounds. The intent, I'm sure, was beneficent to make PCI better, but FAME-3 merely builds on all of the previous less than robust evidence for FFR. Next topic is the ischemia trial challenged. A group of interventional cardiologists publishing in the interventional journal JACC Interventions have made an argument using observational data that one of the most important clinical trials of this generation, the ischemia trial, does not apply to the majority of patients who get revascularization in the real world. Now, reading in between the lines, ischemia is not really practice changing, and its neutral results only apply to a small proportion of patients. Here's some of the quotes made by the study first author, Dr. Chatterjee, in Sue Hughes' excellent news recap. Quote, "While ischemia was a very well-conducted trial, our results show that it only applies to about 1/3 of stable CAD patients undergoing intervention in the U.S. in the real world." Quote, "Ischemia did not really answer the question for 67% of stable CAD patients in current U.S. practice." Quote, "We may be able to defer PCI in these patients, but we don't know that from the ischemia trial as these patients were not included in the trial." Quote, "We believe that patients who do not fall into the ischemia population need a nuanced, individual approach, taking into account symptom burden and patient preferences." Now, recall that the ischemia trial randomized patients with stable coronary disease, moderate to severe ischemia on stress testing, to either initial invasive management with cardiac cath and revascularization, plus medical therapy, or to an initial conservative strategy with just guideline medical directed therapy alone. Patients who had left main, left ventricular dysfunction, end-stage renal disease were excluded from the main trial, and as I've covered on This Week in Cardiology many times, the trial showed no statistical difference in death or MI between the invasive and conservative approaches, and slightly more than 2/3 of patients with positive stress tests and severe coronary disease did not even get an angiogram and still had similar rates of MI or death at 3 years. Ischemia was done because the main criticism of the prior trials, Courage and Berry 2D, that also found no benefit of PCI over and above medical therapy, were that they randomized after the cath and the scariest patients were not randomized. In other words, on external validity grounds. Now, the question raised by the newest observational study is how applicable is ischemia? And the authors using the NCDR cath database found that about 388,000 patients with stable coronary disease got PCI during the time that ischemia was enrolling. But they found that only 1/3 would have met inclusion criteria for ischemia and 2/3 would have been excluded. Specifically, these patients were broken down into 4 groups. 1/3 who were like those in ischemia, so those were included. About 19% who were high risk based on left ventricular dysfunction or left main or end-stage renal disease, the authors say would be excluded. About 17% who had PCI in the real world would have been excluded from ischemia because they were too low risk. And 31% were unclassifiable because of lack of stress testing. So in sum, the authors say, basically ischemia wasn't that landmark of a study because its external validity or generalizability is so low. Therefore, in the face of now the 3rd major trial showing that in stable CAD, initial revascularization does not reduce MI or death, We need not change our thinking on the clogged pipe frame of stable coronary disease. And my comments here is I could not disagree more. First, I'll go over the direct problems with the methods of this observational study, then the more important criticism of the external validity argument. Now, the two lead authors of the ischemia trial wrote the editorial for this paper, and that nicely outlines the unfairness of these four categories of patients in the observational analysis. The editorialists write that first, you can't count 19% of the high-risk patients because patients with left main and left ventricular dysfunction were excluded from ischemia because we already know previous trials have shown that the benefit of revascularization over medical therapy. Second, you can't count patients with end-stage renal disease because ischemia trial enrolled those in the ischemia CKD study. The third point is you shouldn't be counting low-risk patients because it's already been proven in COURAGE and BARRY 2D that PCI did not reduce death or MI. So why are these patients even getting PCI in the real world? And finally, the authors don't have data on 31% of patients in the NCDR registry, so they just assume they would all be excluded. And I don't think that's fair either. In their editorial, Drs. Marin and Hochman recalculate and find ischemia applies to about 2/3, not 1/3 of the patients who got PCI in the real world. And I agree with them. I agree with them that the authors' choices of these groups were dubious and that ischemia remains highly applicable in the real world. I mean, positive stress test in my zip code, these patients go to the cath lab and in most cases, their blockages get revascularized. But I think the greater lesson here is what the authors are implying about external validity. The argument from the quotes from the PI seem to say that the low external validity of ischemia is a reason not to abandon early angiography and intervention in most patients. I think this is backwards reasoning. Here's why. Trials always recruit and select the best patients, the ones most likely to do well with an intervention. Trials represent a best-case scenario. I know of no procedure or drug that performs better in the real world than the rarefied confines of a clinical trial. Every therapy does worse in the messy real world. So it goes with early revascularization. If early revascularization wasn't superior to medical therapy in the best case scenario of the ischemia trial, it would almost certainly do worse in the real world where patients have more comorbidity, less intense follow-up, less medical adherence. So if you say a non-significant trial has low external validity, this is an argument for doing less revascularization in the real world, not more. Because if it can't win in a trial, it surely can't win in the real world. Next topic is the FAME-3 China study. Earlier, I discussed the problems with FFR. Now, what about a different way to assess the physiology of a coronary stenosis? At TCT, a group of researchers from Beijing reported on the use of something called quantitative flow ratio, QFR assessment. QFR does not require the use of a specialized guide wire, and it's easily repeated multiple times during the procedure. Lancet published the study. Now, this was an RCT comparing use of QFR, quantitative flow ratio, which isn't widely available in the U.S. labs, to standard angiography in about 3,800 patients with both stable and unstable coronary lesions. In the QFR was measured on all coronaries with a lesion, but PCI was performed only in the lesions with a QFR of at least 0.80 or a diameter of 90% stenosis. In the control arm, angiography was performed on the basis of visual inspection, in other words, old school. Patients and caregivers were blinded, and the primary endpoint was major adverse cardiac outcomes at 1 year, and the results clearly favored QFR. The composite of all-cause death, MI, or ischemia-driven revascularization occurred in 5.8% of the QFR-guided group versus 8.8% of the angiography-guided group. The hazard ratio was 0.65, highly significant. Fewer MIs and fewer repeat procedures were the main drivers of the endpoint, but here's the key feature of the paper. Pre-randomization plan was changed in 23% of patients with QFR and only 6% in the angiography group. Mainly, get this, mainly due to deferral of treatment of at least one vessel originally planned for PCI. The translation, QFR led to substantially fewer PCIs being performed, less metal in the coronaries associated with fewer major adverse cardiac events, which was exactly similar to the FAME-1 trial. Now, both the editorialist and the trial discussants at TCT pointed out that the problem with the strategy and study was that the new kid on the block, QFR, was not compared to the standard FFR. Well, my friends, the problem with that argument is that the standard FFR doesn't lie on very strong evidentiary grounds, as I talked about. So a neutral Martian would see fewer stents seems to be connected with better outcomes. Final topic today is myocardial infarction as a surrogate marker. A team led by Dr. David Brown from Washington University in St. Louis, first author Kevin O'Fee, has published one of the most important papers of 2021, and I wrote a column on this paper, and it is now up on the heart.org Medscape Cardiology. The question this group had was how good a surrogate marker of death or cardiovascular death is MI. Now, what I mean by a surrogate is an outcome that is on the causal pathway of death. MI seems to fit that description, right? A treatment that reduces MI will likely reduce death. And of course, we need surrogates because over the course of a short trial, like a 2 to 5 year trial, not that many patients die. And when event rates are low, you need huge trials, which are too expensive. And when I trained, heart attacks were devastating. An occluded artery led to a scar, then heart failure, or a VT, or both. And if you had a treatment that reduced MI, that treatment would surely seem to lengthen life. But times change. Brown and his team wondered how well MI reduction correlates with survival. And what they did is they searched PubMed and found RCTs over the decades that tested therapies for both MI reduction and CV and all-cause death reduction. They found 144 trials, and each trial acted as a data point. The amount of MI reduction measured in odds ratios was on the x-axis, the amount of death reduction on the y-axis, and then they drew a correlation line. And what they found is almost no correlation between MI reduction and death reduction. And the type of trial, primary versus secondary prevention, the date of the trial, pre or post 2000, and the length of the trial did not matter. Non-fatal MI still did not come close to meeting the criteria for surrogacy for cardiovascular all-cause death. This, to me, is a huge finding. Trial after trial I've discussed over the years on This Week in Cardiology use MI as an important endpoint. Often MI is the driver of the composite endpoint. But these authors have shown that we should be darn cautious about surrogate outcomes. And you might wonder why MI reduction does not serve as a surrogate marker for death, and I think there are 3 reasons. We now detect smaller MIs, and these smaller MIs are subjected to better therapies. And as our ability to diagnose and treat improves, MIs become less devastating. Second reason, multimorbidity. As patients live longer and with more comorbid conditions, ischemic heart disease represents a smaller proportion of their causes of death. And the third reason, troponin assays now pick up type 2 MI, which are due to supply and demand mismatch. This differs from type 1 MIs where plaque rupture is the cause. And type 2 MIs are treated by treating the underlying cause, say anemia or atrial fib. So therapies directed at plaque rupture will have no effect on the increasingly common type 2 MIs. I'd encourage you all to take a look at this study, read my column. The finding that MI is not a reliable surrogate for death, I think, has huge implications. I have come to believe that evidence needs an expiration date. This study deserves attention because it reminds us to question prevailing dogma. It changes the way we assign values to our therapies, and it will certainly help plan future trials. Kudos to the Washington University team and JAMA Internal Medicine for publishing the study. That's it for This Week in Cardiology. Next week, I'll have some more on renal denervation, which was big at TCT. As always, I'm grateful that you listened. Thank you. And remember, friends, if you like this podcast, please take the time to make a comment, write us a review, and give us a rating on whatever podcast app you listen to. These sorts of things help others find us. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org on Medscape.